Dear Inderes TV listeners and viewers, Mendus released their Q4 report today, and it's my pleasure to welcome the CEO Erik Manting for our first interview.
Hey, Antti.
Erik, warmly welcome to the interview. Many investors don't yet know Mendus very well, so would you kindly start by telling us a little bit about Mendus as a company?
Sure. The company was built up from two companies, actually, one Dutch company and one Swedish company. The Swedish company was listed under the name Immunicum, and the Dutch company was a private company operating under the name DC Prime. And there was one common denominator, which is that both companies had invested a lot in research understanding dendritic cell biology. Now, dendritic cells have a specific place in the immune system, which is well recognized and well described. But to transform the dendritic cell biology into actual product candidates for clinical development and in the end commercialization, that is of course a very different topic. And we felt from both sides that there was a synergy to be created. We have two platforms. The Dutch company DC Prime was working on the basis of a cell line, which we call DC1 cell line, which is a leukemic cell line. So it's actually a cancer cell line, but it's suitable for manufacturing purposes. And the product that is now our lead product called vididencel is derived from that cell line, which means we can make large quantities of the cells and then we transform them through dendritic cell biology into the product which is highly immunogenic and stimulates the immune system. The Immunicum platform was based on healthy donor material, so where we isolate dendritic cells from healthy donor material, and that product was administered into the tumor itself to change the tumor microenvironment. So it was, on the one hand, a very nice combination of expertise and know-how coming together, and on the other hand, bringing together two different platforms. As a company, we are now listed in Sweden because the Immunicum stock market listing was on Nasdaq Stockholm. The operational part of the company is to a large extent in the Netherlands because the lab, the research lab, all the CMC work, so the work we do around our manufacturing processes for both products are all based here in Leiden, where I'm also mostly based as CEO, but of course I'm also regularly in Stockholm where we have our headquarters.
Great. You're focused on cancer maintenance therapy and on patients who are suffering from measurable residual disease. So could you explain a little bit what these mean and why you are focused on these areas?
Absolutely. I think this is maybe one of the key topics, Antti, with respect to not only where we are focused as a company, but also what will drive the next wave of innovation in cancer immunotherapy. So what was established is that the immune system does play a role in the control of cancer cells. It's one of the main reasons we don't develop cancer so often, but also once the cancer develops, the immune system can still play a role. And that was unlocked as a therapeutic approach with the so-called immune checkpoint inhibitors. And what those immune checkpoint inhibitors showed is that there is, in many patients, some level of immunity against cancer cells, but that immunity is blocked by so-called checkpoints. These are pathways used by the immune system, but sometimes are hijacked by cancer cells to basically protect them from being destroyed by immune cells. If you add a checkpoint inhibitor, you break those pathways and the tumor cells are being killed again by the immune system. And that, in a lot of cases, leads to long-term survival, but it's still only working in the minority of patients. And it's only been explored in solid tumors so far in a successful way. So for a number of solid tumors, and particularly tumors with a higher mutation rate, like melanoma, for example, or lung cancer, these immune checkpoint inhibitors have really made a big impact on the outcome for patients. And the biggest checkpoint inhibitor called pembrolizumab is now one of the biggest selling drugs in the world and is being widely applied in cancer therapy. So immuno-oncology, as it's called, has really opened up the field. What's also maybe good to mention is that one of our board members, Andrea van Elzas, was part of the original discovery team that worked on the checkpoint inhibitors that in the end resulted in Keytruda. And there's also a very nice interview in our Q4 report with Andrea for those of you interested to learn more about the broader IO field. Now, with respect to your question, the immune system needs to be trained against the cancer cells. And what we have learned in the past 10 to 15 years with the checkpoint inhibitors is that it's very difficult to overcome that initial success of the checkpoint inhibitors and raising the bar even further, getting more patients into long-term durable remissions. And one of the reasons is that the cancer cells continue to influence the immune system and actually suppress the immune system. So what we decided from an immunological perspective is to wait for situations where the disease burden is low, where the cancer cells are hardly present anymore, but where there is still a very high chance of tumor recurrence or relapse. So that's the setting where we are currently focused on, which is called cancer maintenance therapy, because what you're doing is after first-line treatment, we try to basically prolong the disease-free and overall survival by providing an active immunotherapy. And what I mean with an active immunotherapy is our products, the lead product vididencel, when it is administered, it trains the patient's own immune system to act against the residual cancer cells. And what we start to see now, and we saw it in the phase 1, but now also in the phase 2 trial in AML, it can lead to very durable clinical remissions. And that's what we believe a major breakthrough, not only for us as a company, but also to show that this principle may work.
Your products are called cellular immunotherapies. So could you talk a little bit more about that topic? So what is exactly cellular immunotherapy, and how does it differ from other immunotherapies like these checkpoint inhibitors that you already mentioned?
Yes, I think it's a good question, Antti. I think what has been another revolution in the biotech arena is that we have learned to work with cells, with living cells. So originally, a part of the immune system that was explored more widely is antibodies, which are protein molecules which are made by B cells in the body, but you can also make them now from cell lines, and you can discover them with all kinds of discovery engines. So antibodies are a modality which we are now able to commonly use and also commonly manufacture as a potential therapeutic entity. The cells of the immune system in this case, like T cells and B cells, and we are working on the dendritic cells, they have become therapeutic entities mostly because people have focused more on the manufacturing of those cells and also learning how to work with those cells to apply them for therapeutic purposes. And the major breakthroughs initially came from CAR T, which is T cells that are reprogrammed to recognize cancer cells with a specific receptor that's built into them. That's called the CARs. That's why they're called CAR T. And those CAR T cells can be injected into the bloodstream, and they will find cancer cells and kill them. Now also the NK cell field is opening up. So NK cells, or natural killer cells, are also able to kill tumor cells. So that's the next wave of development. And that is something which has opened up the cell therapy landscape, where there was a specific field open, where we felt we can make the difference, is in dendritic cell biology. Now, dendritic cells train the broader immune system to act against disease. And it can be viruses or it can be cancer cells. But again, to transform that into a therapeutic concept starts with manufacturing. So we've invested a lot in the manufacturing of our products, and we know we can make what's called off-the-shelf products, so products that have been manufactured in large quantities, they're stored frozen, they're ready for patients to use. So it's a relatively straightforward method of getting cells to patients as a therapeutic approach. The other very important part is that you need to understand the biology of your product. So we've invested a lot in how these dendritic cells actually interact with the immune system. And what we found out is that our products basically train the patient's own immune system. That's also why we call it an active immunotherapy. It means that our products leave an imprint on the patient's immune system, which is long-lasting. It's built on immunological memory. It is a trained immune system that is able to, over a longer period of time, control the disease. That makes it very different from CAR T or NK cell-based therapies, which are injected into the patient's bloodstream to immediately act, but which have a short-lived effect because they act immediately, but they don't train the patient's immune system. So there are different elements that I think are important to understand how we approach cellular immunotherapy with our dendritic cell know-how. But the most important parts are we focus on off-the-shelf products with scalable manufacturing, And our products train the immune system in an active way. So it trains the patient's own immune system. And maybe as a last remark, Antti, because I think it's maybe also not always explicit, a lot of these cellular therapies require quite heavy treatment of patients before they can be administered. For example, that's called lymphodepletion. You need to reduce the patient's own immune system to be able to give CAR-T, because otherwise you get all kinds of side effects that can be very dangerous for patients. So it requires a lot of preconditioning to be able to administer the therapy. Our therapy, which is based on these dendritic cells, is very safe. We administer it either in the skin, which is our vididencel lead product, but we can also administer them into tumors. But because they train the patient's own immune system, the patient's immune system has to be there. We don't suppress it. We don't, try to destroy it to be able to give our own approach. It's a very safe approach. And again, it leaves a long-term impression on the immune system of the patients.
You already mentioned your lead product is called vididencel, and quite a lot about its safety and also something about its efficacy. So could you summarize a little bit what is known from current and past clinical trials?
Yes, we started with vididencel as a cancer cell, which is transformed into a dendritic cell. And we first wanted to understand how that interacts with the immune system. And what we discovered is that the product immediately activates the patient's own antigen-presenting cells. And for example, in the skin where we administer the product, there's a lot of antigen-presenting cells because the skin is a natural barrier to entry for infections, for example. And we saw that these antigen-presenting cells phagocytose, which means they eat our product. And we can visualize that by making our product fluorescent, for example. So we knew how the product interacted with the immune system, which is it trains basically the patient's own antigen-presenting cells to capture these cancer antigens, which are part of our product, and present them to the immune system. Then when we looked into the phase 1 data, so our first clinical trial data, we discovered something else which was striking, which was first, we saw durable remissions, even in very high-risk AML patients, but we only saw them in patients with a low disease burden. This is a paper we published last November, which was a more in-depth analysis of our phase 1 trial. But what you see in that paper is that the strongest correlation between successful treatment and durable response is a relatively low level of cancer cells at the start of the vaccination. At the time when patients are already relapsing, so they have very high levels of tumor cells, the vaccination no longer works. So that set the stage for the phase 2 trial, which we are currently running, which is with only patients in first complete remission. So they have undergone chemotherapy, their disease is down, but we can still detect it. And that's called MRD, or measurable residual disease. So with sensitive methods, even though the patient is officially in a complete remission, you can pick up that there is residual cancer cells, and these cause a very fast relapse in AML. And that's the setting where we are currently applying vididencel. And what we have learned is that in the majority of patients, there is still a relatively good immune system, even after high-dose chemo and even after already a first bout of AML. And the majority of patients, 14 out of 20, responded with a very strong and robust immune response to the vididencel treatment, and more importantly, are still alive today in long-term follow-up, which is now already over 30 months. And the relapse-free survival median, so the median survival without disease, is now at 2.5 years. So we're really looking at a very durable clinical remission.
That sounds great. You released your Q4 report today. So could you summarize the major milestones of last year, and also what can we expect from Mendus this year?
Yeah, so last year we had initial good data from our phase 2 trial, which were presented at the ASH conference December 22. For the first time, we saw long-term survival in our phase 2 trial. And this, of course, raised the question, what are you going to do next? And we knew we had to take 2 major steps, which was one, to set up a trial with the current standard of care. So when we did the trial, it's a monotherapy trial, there was nothing. Today, there is a tablet form of azacitidine called oral azacitidine as a maintenance therapy in AML. So we knew we had to set up one way or the other a larger randomized controlled trial with oral azacitidine. That is something we announced last year we can do together with the Australasian Leukemia and Lymphoma Group, ALLG. And together with them, we will run a trial with vididencel in combination with oral azacitidine, first in a group of 40 patients, and then with the possibility to extend it to 140 patients with an additional 100 patients. So a very sizable trial in combination with standard of care. The other major hurdle we had to take is the manufacturing, because we have a current manufacturing process, we have enough material to run our upcoming trials, but to prepare really for late-stage development and commercial launch, you need to be able to manufacture your product in much larger quantities. And for that, we needed a manufacturing partner, because we are not a GMP facility, a good manufacturing practice facility. You need a specific manufacturing facility for that, and we were able to team up with a company called Northex Biologics, and with them now we are building out our manufacturing process. So those were major steps in preparing for late-stage development of our product, and those are the steps that we took last year. Now, of course, the trial, which is called Cadence trial, will start with oral azacitidine in the first quarter of this year, and will deliver data in combination with standard of care. We are working already since the summer of last year with Northex to scale up our manufacturing. So we are preparing for late-stage development. And that's the other big effort we will put in this year to make sure that as a company, we also know what needs to be done to get the product over the finish line. And whether we will do that by ourselves or with a partnership is obviously also something that we are carefully looking into. Next to that, we have the vididencel program, so the intratumoral primer, that we are planning to get back into the clinic. We have made that product stronger. We've worked at the manufacturing process. We looked at the clinical positioning. We want to develop this product in soft tissue sarcomas, and that's a trial we are currently preparing for. And we have a trial in ovarian cancer ongoing, which is called the Allison trial. And that trial will read out in the second half of this year. So we're also looking for the data from that trial to see how we can potentially move forward in ovarian cancer.
Final question for biotech companies. The cash position and cash runway is always an interesting question. What is your situation in those terms, and what are your plans for the future?
Well, also very importantly, last year we raised money, 317 million Swedish krona between June and August. The transaction was announced in June and completed in August. And it means that we now have 2/3 roughly of our shares with large institutional investors. That's, of course, for us a very important basis to move the company forward. We, as you may appreciate, cannot be more specific as a public company about our next financing efforts, but obviously we're keeping all options open to see how we can take the next steps in moving forward our lead product and then also the rest of the clinical pipeline.
Erik, thank you very much for the interview. It has been a pleasure to have you.
Thanks, Antti.